Hi everyone, my name is Allie Swartz. I am a nurse practitioner student. I currently work as a nurse on cardiology at UW, and I had my last clinical with Sarah in the spring of 2016. I just wanted to give you a brief overview on sleep apnea and how primary care providers can really help to identify sleep apnea. Um, I'm planning to roll out a quality improvement project at the end of December, early January, that utilizes a protocol for routine screening for sleep apnea. So I just wanted to give you guys a little bit more information on the current guidelines related to sleep apnea. And I also wanted to talk about stop bang as a screening tool, as well as the physical exam findings that should be included in the assessment for sleep apnea risk. So it's estimated that up to 32% of patients in the adult primary care setting in the US suffer from sleep apnea. Unfortunately, 82% of men and 93% of women remain undiagnosed. I find it interesting that 1 out of 5 white men and women with a mean BMI between 22 and 28 have at least mild sleep disordered breathing. That kind of tells me that if we're just screening the obese male that snores, we're going to be missing a lot of people. So I think primary care providers are in a critical position to help identify those at risk for sleep apnea, so intervention can be started sooner than later. There are a number of common comorbid conditions that are associated with untreated sleep apnea. So when you have sleep apnea, you're stopping breathing at night, which causes the activation of the sympathetic nervous system. This causes the release of hormones such as epinephrine, which cause vasoconstriction, hypertension, which also causes heart failure. So it's kind of a vicious cycle, and a lot of these conditions are intertwined. Um, Other risk factors include excess weight, narrowed airway, chronic nasal congestion, smoking, diabetes, male sex, family history of sleep apnea, and asthma. So the consequences of untreated sleep apnea, I think a lot of us know that cardiovascular disease is a huge problem. Others include depression, memory issues, irritability, um, stroke, insulin resistance, and there's also been an increased all-cause mortality. So the American Academy of Sleep Medicine guidelines recommend um, that primary care providers evaluate for sleep apnea on one of three occasions. So A, during routine health maintenance exams, B, when the patient complains of symptoms, or C, when they are considered high risk based on their comorbid conditions that we just talked about. So literature shows that most primary care providers are not addressing sleep issues unless they're brought up by the patient. Many patients will not bring up sleep issues because they feel that snoring and daytime fatigue is normal. The review of system questions are not specific enough to address sleep concerns, and there are a ton of other concerns, and sleep is not necessarily a priority for the patient or the provider at these visits. So when I did a needs assessment back in July, I found that only 8% of providers routinely screen for sleep apnea, and 54% are unfamiliar with current guideline recommendations. 69% of providers felt that resources are not readily available to help screen for sleep apnea, and less than a quarter felt comfortable with certain assessment components that are related to sleep apnea risk. So there needs to be an accurate screening tool that is sensitive and specific to help identify those that are symptomatic and high risk. This will be a cost-effective way to help predict sleep apnea, and it can also help highlight the need to refer patients to a sleep specialist. So there are three main questionnaires that have been pretty well studied in the primary care setting, and that's the Berlin questionnaire, the Epworth Sleepiness Scale, and the Stop Bang questionnaire. I won't get into too much detail, but I just wanted to mention quickly that the Epworth Sleepiness Scale is not a great tool to use for sleep apnea screening. It only helps to assess daytime sleepiness, which is a symptom of sleep apnea, but because there are a number of causes to daytime fatigue, it's not a great tool for that. So the Stop Bang is the tool that we decided to use for the screening protocol at University Station. It's going to use both subjective and objective measures. It will assess snoring, tiredness during the day, observe periods of apnea, hypertension, BMI greater than 35, age over 50, and neck circumference over 16 inches, and the male gender. It's been used in the pre-op and primary care population, and it's been found to be easy to use and score, and found to be very sensitive and not as much specific, but it is ultimately preferred by the Wisconsin Sleep Clinic. So a score of 5 or more is considered high risk. A score of 3 or 4 is considered intermediate risk. So if they have intermediate risk, you're going to want to look at what they scored positive on. If they have a score of 2 plus they're male, they have a BMI over 35, or they have a neck circumference of over 16 inches, they're going to be considered high risk. So the review of screening tools showed that there are varying psychometric properties which makes validation difficult. The screening tool should be highly sensitive and specific, but most are not specific. They do, however, increase sleep apnea risk identification compared to simpler review of system forms, and they have promising accuracy for screening for sleep apnea. So if they do screen positive for on the stat bang, we can't just rely on that. We have to use our assessment skills. So we want to consider associated comorbid conditions, what are their symptoms, and what are the physical exam findings. I talked a lot about the conditions already that are associated with sleep apnea risk. I also wanted to mention high-risk driving populations and those that are preoperative for bariatric surgery. So questions that should be included on the routine health maintenance exam are, is the patient obese? Is the patient retrognathic? Does the patient complain of daytime sleepiness? Does the patient snore? And does the patient have hypertension? All of these are included on the stat bang questionnaire, except for, is the patient retrognathic? This can be easily identified on physical exam. Some common symptoms that we think of when we see sleep apnea are obviously snoring, apneic periods during the night, excessive daytime sleepiness, poor quality of sleep. Other ones that we don't necessarily think about, maybe morning headache, insomnia, memory issues, nocturia, impotence. So the physical exam components that are important to assess would be the oronasopharynx. The Mallampati scale is a rough estimate of the tongue size relative to the oral cavity. And you're going to want to have the patient open their mouth without using phonation. So you don't want them to say ah. You just want to look and see. If you can see the tonsillar pillars, they're going to be less than a class 3. If you can only see the soft and hard palate or just the hard palate, they're going to be 3 or 4. And class 3 and 4 are correlating with a sleep apnea risk. If the tonsils are enlarged, you're going to obviously see a more narrow airway, and that's going to lead to obstruction. Look at the uvula closely. If you see kind of redness, it could be due to repeated trauma from snoring or GERD. If the uvula is enlarged, it can also cause obstruction. So retrognathia is a retruded mandible, which causes the tongue to drive back into the throat and blocks off the airway. The tongue can elevate the soft palate, which then will block off the airway and eustachian tubes. The small or recessed jaw can also predispose someone to airway obstruction. An overbite is a common type of dental malocclusion, and that's also associated with sleep apnea, as well as a scalloped tongue, which could be due to the jaw being too small for the normal sized tongue. So you'd see kind of these ridges on the edge of the tongue. Also, macroglossia is another term for a large tongue. The high arched and narrow palate causes the tongue to sit very high in the mouth. So when you have them open their mouth, you won't be able to see the back of their throat very clearly. The elongated soft palate narrows the opening from the nose into the throat, and the excessive length of the soft palate and or uvula acts as a noisy flutter valve during relaxed breathing. You're going to want to measure the neck, and if women have a neck circumference over 16 inches, they're going to be considered at risk, and men with a neck circumference over 17 inches are considered at risk. So sleep apnea is less prevalent in women for a number of reasons. They have smaller lateral parapharyngeal fat pad size. They also have smaller soft tissue structures in the upper airway, and they have an increased genioglossus muscle activity, which causes greater upper airway stability. This muscle activity is greater before menopause, and after menopause, women are at risk. So other features in women that are associated with sleep disordered breathing would be the narrow hard palate, a variable overjet, triangular chin, or the overbite. Some craniofacial abnormalities and maxillomandibular malformations predispose people that are not obese to sleep apnea. I would encourage you all to use HealthLink Smart Phrases to help kind of prompt you in your examination. So the .OSA will help kind of trigger different questions to ask about a number of symptoms that patients might be having that are associated with sleep apnea. Also, the .OSAHEENT is a great guide to kind of include all those different oronasopharynx findings. This was from the Wisconsin Sleep Clinic, and I will share these smart phrases with you. You want to educate the patients about their condition and their risk, as well as the consequences of not treating the disease. You want to make sure they know that treating is non-invasive, non-medical, and testing is painless and non-invasive. And it ultimately will improve their quality of life and also their life expectancy. So this is a flow sheet of the protocol that I would like to implement for my quality improvement project. I'm going to pre-review charts and determine who will be eligible. So that's going to be patients who do not have a diagnosis of sleep apnea who are coming to the clinic for routine medical exams. The rooming process is going to be exactly the same. The MA is going to take the blood pressure, height, weight. The only thing that is going to be different is that they're going to give the patient the stop bang questionnaire, and this will be something that the patient can fill out if they want. They don't have to do it. And the MA will write their BMI on the questionnaire. So the provider is going to come in and score the questionnaire. And then if they score a 5, they're going to be considered high risk. If they score a 3 or 4, you're going to want to look at it a little closer and see what exactly they scored positive on. If they have a score of 2 or more and are male, or they have a BMI over 35, or have a neck circumference over 16 inches, those are going to be considered high risk findings. So they should be referred. If not, you're going to want to look at physical exam findings and see if there are any symptoms that are suggestive of sleep apnea. And if those are positive, then you'll want to refer. So you can give your patient some information about the sleep study that they might be undergoing. The in-lab study is the polysomnography that is gold standard for diagnosing sleep apnea. The portable monitors or the home test have also become more frequently used. They're cheaper. Patients can do them in the comfort of their own home, and it's just more convenient. However, it does not include an electroencephalogram component and doesn't distinguish between REM and non-REM sleep. The portable home monitor monitors the number of apneas and hypopneas per hour of recording time, and the polysomnography looks at the actual duration of sleep. So the one caveat about the portable monitors is that the patient must have a high probability of sleep apnea, and they also cannot have any other comorbid like major medical disorders. So the absolute contraindications for the home sleep studies are daily use of narcotic therapy, if they use oxygen at night, if they have restless leg syndrome or other chronic conditions like heart failure, stroke, neuromuscular disease, or moderate or severe lung disease. So prior to patients getting the sleep studies, we can talk about some behavioral changes that they can make that could improve sleep apnea symptoms. So avoiding alcohol, sleeping pills, sedatives, or narcotics before bed. Weight loss of 10% can also improve snoring. Keeping off your back, so using a fanny pack that has tennis balls and kind of wearing it backwards can help people stay off their back at night. And then the use of chin straps can also help keep the chin from laxing and help kind of keep the jaw forward. Also, if they have allergy problems, making sure that they avoid their triggers and use the medication that they need. So CPAP is the first line therapy. It provides pressure to upper airway during sleep and helps to stabilize airway walls. It improves daytime function, daytime sleepiness, and quality of life. And studies have shown improved cardiovascular outcomes for patients that have both mild, moderate, or severe disease. So a separate long-term observational study that lasted 72 months stratified patients by severity found that CPAP treatment was associated with a cardiovascular risk reduction of 64% for the whole study group. Patients, and this also included patients with mild to moderate sleep apnea after adjustment for age, BMI, and pre-existing cardiovascular comorbidities. So strategies to support CPAP adherence are important to take into consideration. You want to make sure that you have a general idea of some of the main problems that patients are coming in with complaints of, or kind of what's prohibiting them from wearing their CPAP. A lot of them are easy solutions, even just adding humidification or trying a different type of mask. It's important for the primary care provider to kind of troubleshoot this and kind of guide them in the right direction so that they can become more adherent. Here's another list. I'll keep this in the office so that you guys can refer to this if you need to. So in conclusion, sleep apnea is a chronic condition that is widely underdiagnosed. It leads to a number of poor health outcomes if left untreated. The current model of screening and assessment for sleep apnea is fragmented and ineffective, and testing of sleep apnea screening tools must be conducted in large-scale nationwide studies that assess implementation in the primary care settings. We have to look at other symptoms aside from snoring, and patients also might have kind of subtle symptoms or physical features that put them at risk. We also need to consider their comorbidities, and just keep in mind that CPAP therapy is considered the first-line treatment and has a significant impact in the reduction of cardiovascular events. So I just want to thank you for your time. I appreciate your listening, and if you can fill out the post-test and feedback survey, I would appreciate it. Also, my information is listed here. You can email me with questions or concerns or comments. I thank you, and I look forward to working with you all.